good morning, good afternoon, good evening, wherever you are, because people are joining in globally for this webinar. So welcome. I also wanted to thank our panelists, especially Dr. Carlos Blanco from the NIDA, Florence Jaguga, and Farid Kamani for joining us today. And Candy will be formally introducing them in a minute. But I wanted to say thank you for participating in this webinar. As you know, we have launched this course, which is sort of a micro certificate in mental health ambassadorship. And the reason we've launched this course is based on the need across the campuses and societies that we work with, that people want to understand mental illness better. And so this course is designed for that. And the webinar series that we are participating in this right now is a part of that course. But the other part of the course is more a didactic lecture that actually tells you about what different mental illnesses look like, how to detect them, how to respond to them, and things like that. So together, these two components play out the ambassadorship microcertification course. Now, we hope that through this type of an approach, that we will not only understand mental illnesses better, so that then we respond to people more empathetically, kindly, more supportively, but also shed some of the stigma that we have about mental illnesses and hence set the pathway to get the right type of care at the right time. So this course essentially, as I said, will have a core component that talks about what mental illnesses are, but then the webinar series right now that we're participating in is designed to shed light on some of the biopsychosocial determinants of ill health. And so what contributes to mental illness is the purpose of these webinars. And hence, I will now tell you a little bit about the Brain and Mind Institute. So if I may share my slides. So the Brain and Mind Institute at the Aga University has two major hubs. One is in Nairobi that serves East Africa, Kenya, Uganda, Tanzania, and one in Karachi that serves South and Central Asia. Our vision is healthy brain, healthy world, and our mission is that we would advance brain health through collaborative research, education, and innovation in mental health and neuroscience. And so these are the four pillars that actually the Institute kind of works through. Research, of course, because we are a research institute. Innovation and translation, because we want to use the research to inform care and learn about what the care needs are so that the research would be properly designed along those lines. Education, which is part of this series, and other ventures, and then engagement and partnerships. So those are the four major pillars for the Brain and Mind Institute. And our research focus is on depression and anxiety, on stress and trauma, and on suicide prevention research. These are overlapping constructs, but really the core areas where we would like to focus most of our activities. And last but not least, I'd like to say that we're not building an ivory tower, we're building a collaborative tent whereby everybody, communities included, become part of our family. And so the old proverb in Africa, we say, if you want to go fast, you can go alone, but if you want to go far, you go together. And so that's the underlying premise. So we say from the neuron to the neighborhood is the motto for the Brain and Mind Institute.
And so now we meet our panel members. First off, I would like to introduce Dr. Carlos Blanco. Dr. Carlos Blanco is the Director of the Division of Epidemiology Services and Prevention Research at the National Institute of Drug Abuse. We'll be sharing more about him in the chat. Please feel free to read more. We also have Mr. Farid Diamond Kimani, who is a presenter and radio host with Kenya's Capital FM, who has heritage in both Pakistan and Kenya and will be sharing perspectives around his lived experiences based off of his heritage. Last but definitely not least, we have Dr. Flores Jaguga, who is an implementation scientist consultant with the Brain and Mind Institute, who's been tasked to conduct a baseline mental health survey of the undergraduate and postgraduate students at the Aga Khan University campuses. Welcome, panel members, and I think we just move straight on to Dr. Carlos Blanco so that we're able at the end of this to have some sufficient time to answer the questions that you ask. Welcome, Dr. Blanco.
Thanks very much, and really an honor and a pleasure to be able to share the panel with all of you and exchange perspectives, and especially about this topic, which is one of my favorite topics of all. So let me share my screen. I'm going to talk a little bit about some epidemiological and clinical data on what comes first, and then again looking forward to the panel discussion and the different perspectives that we may have from our either lived experience or clinical experience. So when we think about what comes first, I think we are asking sort of two different related but different questions. One is the temporal precedence. What happens first, what is that we see first clinically, but also we're asking in terms of causality, does traditional psychiatric disorders like anxiety or depression cause addiction, or is it the use of substances that trigger the mental illness? But there's another possibility, which is not that one causes the other, but rather, as I think Candy was sort of implying in the introduction, that there may be sort of shared causes or shared etiology for both types of disorders. And let me clarify that of course substance use disorders or addiction is a type of mental illness, but often we differentiate it or separate them for didactic and treatment purposes. And so I'm going to talk a little bit about the temporal precedence and the causality, and then at the end talk a little bit about the implications at different levels. And again, hopefully this will trigger later on the discussion. So when we look at epidemiological data, these are data from a study called the NESARC, which was done in the United States about 10 years ago, which collected information about 36,000 people. And as you can see on the different lines, if we just look at temporal precedence, anxiety and depression in general occur before substance use disorders. And to a certain extent, that makes a lot of sense, because to experience a substance use disorder, you have to be able to use substances, and most children cannot access substances. So even though, let's say, somebody might be predisposed to a substance use disorder, unless you use alcohol or tobacco or cannabis or some other drug, you're not going to be able to develop the substance use disorder. So in terms of temporal precedence, or in terms of what we may see clinically, it is more likely that the person will have symptoms or even meet diagnostic criteria for an anxiety disorder, like generalized anxiety disorder, social anxiety disorder, panic disorder, or for the mood disorder, let's say depression or bipolar disorder, before they have a substance use disorder. But if we think in terms of causal models, there are sort of two ways of thinking about this, as I was saying before. One is what we call the common liability hypothesis, and the second would be what we can call the predisposing hypothesis. So the common liability hypothesis posits that there's essentially a shared cause or a shared etiology for both traditional psychiatric disorders and addiction. An example of whereas the predisposing hypothesis would say that one disorder causes the other, no, in one direction or the other. So if we think in terms of general medicine, for instance, if we have an infection, let's say we have a GI infection, a common liability when we think about the symptoms. So somebody may have fever or vomiting. We think that as a shared liability hypothesis, because we're thinking that the bacteria, the the infection is causing both symptoms. It's not like the fever is making somebody vomit. So this is sort of a common cause that is causing all these symptoms. Could cause diarrhea. So, but this is the same. Whereas if we think about the same infection, but then the person gets dehydrated, we think that vomiting or diarrhea caused the dehydrating. So it would not be a shared cause here. One symptom or one symptom is leading to the other. No. So when we think about this in terms of psychiatric disorders, what I'm showing here is a graph of a study done in about, it was done in 1999, so about 23 years ago. And this is also a very large survey. And what you can see here, I mean, this is a very complicated graph, but essentially what it is saying is that psychiatric disorders, including, as you can see at the bottom, addiction, often occur. And when you do some statistical models, you can see that these disorders cluster and essentially seem to, at least in part, be explained by a common cause. And to me, that makes a lot of sense, no? Because many of the risk factors for psychiatric disorders, let's say childhood maltreatment, genetics, the way the environment in which we grow up. I mean, even if you think at a more basic level, we only have one brain, right? So to the extent that both addiction and mental illness are in the same brain, it makes sense that they would co-occur and that they would at least have some shared liability, some shared etiology, and some shared mechanisms. And also in terms of consequences, this is the way in which we can group disorders. So again, this sort of intermediate column shows that psychiatric disorders can be grouped in a limited number of liabilities, but then those liabilities or this general psychopathology factor that would explain in part both mental illness and psychiatric disorders, as you can see, explain the consequences of disorder. So whether we have had trouble in our relationships, or whether we have problems with neighbors or unemployment, quality of life, many of these things are really better explained by these shared factors, by these shared liabilities, than by individual disorders. So all this is telling us that at least in part, addiction and mental illness have a common cause, a common liability. Then another thing I wanted to mention, because I think it's clinically very important, is what happens if somebody has both a substance use disorder and a mood or anxiety disorder. If one remits from one of the disorders, let's say in this particular slide, what I'm showing is if the person remits from a substance use disorder, is there a greater or lower risk of developing other disorders? So as you can, here the most important line is the one that you can see after years now. So this OR, which is the odds ratio, and any odds ratio that is below 1 indicates that it is less likely to occur. So if somebody remits from a substance use disorder, you can see on the right side of the slide that the probability of developing a substance use disorder 3 years later, another one. So let's say you remit from tobacco, the probability of developing alcohol use disorder is 0.4. So if you remit from a substance use disorder, that is going to protect you from developing another substance use disorder in the future. And the same for mood disorders, and the same for anxiety disorders. So if you remit from a substance use disorder, if you remit from an addiction, that's going to protect you from a mood or from an anxiety disorder. So that in a way is telling us that even though there are these shared causes that I was talking at the beginning, there may be also a causal component between addiction and mental illness. And so in this particular slide, I'm showing if you remit from a substance use disorder, but the mirror or the converse is also true. If you remit, you can go back to this line, to the OR, to the odds ratio. If you remit from a mood disorder, you can see that later on, 3 years later, the probability of developing a substance use disorder, a mood disorder, or an anxiety also decreases. So if we are able to treat or to cause remission of mood disorders, that's going to have a protective effect on the addiction. So it goes both ways. No? So the causality, at least in part, goes in both directions. And of course, I'm talking here on what happens at the population level, what happens on average. As clinicians, we of course know that each person is different and the symptoms may be different. But I'm talking, in terms of getting sort of a general concept, which I think is very useful in medicine and in sciences general. On average, if one disorder improves, if mental illness improves, then addiction is going to improve. If we're able to improve addiction, then mental illness is going to improve. So here the same for anxiety disorder. I realize that the slide is very busy, but I just wanted again you to focus on the odds ratio. And since I know that you're going to be able to access the slide, I thought I would put as much detail as possible. But the main message, as I said, is if you remit from one disorder, you are sort of developing protection moving forward towards other disorders. I want to also talk briefly about data from another study called the NISARC-3, which was also a very large epidemiological study conducted in the US. And as you can see, it collected data on about 36,000 people. And here, again, I just want to reiterate the idea that when you look longitudinally or when you look sort of clinically, anxiety and depression appear earlier. But then one of the things that we did, and again, this slide is very complicated, and so I don't expect that we will be able to grapple with all the numbers, but I want you to have the documentation. Essentially, what we did is not just look at what happens clinically, but taking into account that disorders happen at the same time, but the epidemiology of addiction and the epidemiology of anxiety are different. If we compare what we see in the epidemiological sample versus what would happen if, again, take into account the natural history of the disorders versus what would happen if people got randomly the disorders, then we can look at the sequences of what happens first. And here what we see is that what we would expect is that if we take into account how the disorders are distributed, anxiety and depression would happen before substance use disorders less often than one would expect. So again, we're using a little bit fancy statistics here. I put the reference below in case somebody is interested in looking in detail at the statistical method that we use. But essentially what this data, and again, I'm presenting 3 slides, so only 2 slides on this, is that there seems to be a little bit of indication that there's causality. So even though in the first part of the talk, I mentioned that there are shared risk factors, and we have the same brain and shared etiology for disorders, there seems to be also a little bit of causality. And the causality seems to go in the direction that on average, substance use disorders tend to increase the risk for anxiety and depression. So even though many of you may be familiar with the self-medication hypothesis, what the epidemiological data seem to indicate is that for the average person, again, each patient is different. For the average person, the self-medication hypothesis doesn't seem to hold true. It is actually the opposite, that by consuming substances and developing substance use disorders, in a way, our brain gets damaged, and that increases our vulnerability for anxiety and depression. Now, what does that mean? And this is the last slide, because I wanted to leave time for questions later on and for the panel. So I think this has implications at different levels. At the first sort of theoretical level, when we think about etiology, our conclusion from the data is that in a way everybody's right, no? So part of the reason why disorders occur, part of the reasons why addiction and mental illness occur, is that there's a common liability. So as I was saying, there's a common set of risk factors. We grow up in the same environment, we have the same brain. So it makes sense that there would be a common liability or shared etiology. But at the same time, there's also causality. So, and that causality, as I was saying a moment ago, seems to go from the substance use most frequently. I mean, it can go in both directions, but most frequently it goes from the substance use disorders to the anxiety and depression. In terms of what that means clinically, so in terms of screening, because substance use disorders and addiction occur so often, it makes sense for people who have substance use disorders to be screened for common mental disorders like anxiety, depression, bipolar disorder. In terms of prevention, I think it has two implications. One is that because addiction and mental illness have shared risk factors, by preventing those risk factors, let's say by acting or preventing childhood maltreatment, or by addressing impulsivity, or by improving family environment, we're going to be able to prevent both sets of disorders. So I think that's very important, because in terms of, let's say, cost effectiveness, there will be what economists call a spillover effect. No? So we are not only benefiting one thing, but we're really benefiting across the spectrum of benefits. No, again, if you think about something in general medicine, just by exercising, we're decreasing stress, we're improving cardiovascular health. So here is the same: by acting on these sort of shared risk factors, we're benefiting both, or we're decreasing the risk of both mental illness and psychiatric disorders. And then at the level of treatment, as I had shown in the previous slides, if we're able to achieve remission in one of the disorders, let's say substance use disorders, that's going to protect or help remit the other disorders. So by treating either substance use disorders or by treating mental illness, we're going to improve not only that disorder, but really the other one. So my conclusion is that even though it's intellectually appealing to know which one happened first, at the end of the day, as clinicians, as mental health workers, we really want to address both, because by benefiting, by acting on one or benefiting on one, we're going to benefit the other one. And as we all know, not only by helping our patients, not only are we helping them, but we're also helping their families and their loved ones. So there are spillover effects at the level of the disorder, but also more broadly at the level of their families and the level of society overall. And with that, I want to finish my presentation, and thanks all of you for your attention, and looking forward to the other panelists and then the dialogue with all of you. And thanks for inviting me to be part of your presentation.
Exactly, Dr. Blanco. Thank you so much for that. I think that was quite insightful, especially considering that it's not so important what causes what, but treating both. I think now we move over to Farid Kimani. And thank you so much, Farid, for being here. Maybe you could share your perspective as with lived experiences and generally that perspective, so that we can see your experiences, the experiences of other persons with lived experiences contributes or speak to the conversation at hand.
Sure. Thanks very much. And that was extremely interesting. Thanks very much, Doctor. That was something that will definitely stay with me. I think it's important to start with a little bit about my story for those who don't know it. I mean, it is quite a public story, but vitally important to highlight a little bit of my story. So I obviously have had my struggles for 25 plus years with addiction, both class A narcotics and alcohol as well. And through that period, I had no idea why the addiction was why it was what it was. What was quite interesting, and only came to really realize it following my stay in a treatment facility in South Africa, was that when I checked into the facility on the first night, they give you Valium, because obviously they're concerned about the physical withdrawals of the substances. But I remember leaving 35 days later, and the 2 Valium they gave me were still sitting on the bedside table of my room. I had no physical withdrawals whatsoever, none, zero. I saw people in the facility going through physical withdrawals of addiction, and I can identify with and know what that looks like now, obviously, but I had none, zero. First night in treatment, I slept very well, and throughout. I didn't have any shakes, any aches or pains, any sweats, nothing. When I came, I did a lot of private therapy, excuse me, in the facility as well, and we started to get to the root of the problem. But only when I came back, started to go to a counselor here, did I discover that and this is the belief I have, but through a lot of therapy and counseling, my addiction was a symptom of a much bigger problem. My inability to be comfortable in crowds, my inability to be comfortable where there's conflict surrounding me, my fear of social situations, my anxiety in certain elements of my life were driven by what I now know was a very difficult and volatile upbringing that was never addressed and only started to become addressed at the age of around 43 through treatment and then post-treatment as well, that my dependence on substances was not physical at all. It was actually an emotional and mental dependence, in my opinion, because I didn't have any physical withdrawals, and the hard drugs that I was using were substances that would cause some sort of withdrawal. So that's my story in a very small nutshell. But to just reiterate what the speaker before stated, I don't think it's as important to focus on what is the cause or the reason for the other, but more importantly, how do we reach out to as many people as possible and start having these conversations. Part of my my new direction in my public persona is to be as open and giving of my story as I possibly can, because I do think that these conversations are not had enough. I wouldn't have been able to have this conversation at my dinner table with my parents, but I hope one day my children can bring up things like this at the table with me. So I'm a firm believer in dialogue. My therapy has also taught me that I can live in these situations that used to scare the hell out of me, actually, even with fear and anxiety. But there are tools and tricks and tips to manage that I use. It's not as if there's a magic wand that kind of, you're now cured from it. No, I mean, obviously I do know that I'm an addict and will be an addict for the rest of my life, which I'm a very comfortable saying and very proud to wear it on my sleeve. And what I try to tell young addicts now is basically that you can turn it into less of a disease and more of a superpower. You can own that addiction and be proud of your addiction because you're doing something about it. But just going back to the mindset of what comes first. So I'm a believer that my addiction was a symptom of a bigger problem, which was covering up a lot of pain from the past, a lot of abandonment issues as a child, a lot of fear of, I had a lot of threats when I was young that I was going to be left alone. And on, some occasions, not for long periods, but it had happened. And I think a lot of that led up to the fact that I had a lot of fear and things that I tried to cover up. And, my first drink was a great feeling. And I felt like, oh, okay, so this is how I'm going to manage these problems and these feelings, not really knowing what they were. But then I spent the next 25 years trying to chase that high, So it wasn't really something that worked in the end. And I ended up in a treatment facility. But again, just before I close, I would like to say that panels like this, where you bring in, experts from the scientific side, and also I do believe that, there's a generation that will want to hear the story of someone who's lived through it. And I think that's vitally important, and I see my role to play in that as well. I do have to make it very clear to a lot of parents that I'm not a therapist, I'm not a counselor, and I can't give advice. All I can do is tell my story. Thank you.
Thank you so much, Farid. And so I think your perspective, especially as a person with lived experiences, really sheds light on the fact that it's not really too easy to determine which comes first. And from one person to the other, it could be one leading the other. But from your perspective, it was your childhood trauma that contributed or perpetuated or encouraged you to sort of pushed you in that direction. Thank you for sharing your story and being honest about that. I think
Sure.
now we can listen to Dr. Jaguga, and she'll give us a Kenyan perspective as a clinician and someone that's been doing research in the area. And so let's listen to you, Dr. Jaguga, and then we'll begin a conversation and responding to some of the questions that have been asked privately and in the Q&A section.
Thank you, Candy, for inviting me. And thanks to the presenters who've come before me, Dr. Blanco, for your expert perspectives, but also thanks, Farid, for sharing your lived experience. And for me, just listening to the presenters before me, I mean, what they talk about really echoes what I see happening here in Kenya. I am an early career psychiatrist. I think I still am. I have worked for 4.5 years now, and I have worked in the substance use field for that time mostly. It's really an area that interests me quite a bit. In fact, my thesis work was looking at the prevalence of substance use disorders among patients with mental illness. And then right after that, after graduation, again, I looked at the burden of mental illness among patients with substance use disorders. And so from that work that I did, the research work that we did, and also from my clinical practice, I do see that these things work together a lot. They do happen together a lot. In fact, the work that we did at the rehab here, where I work in MTRH, we found that 100% of patients who are seeking treatment for addiction had at least one mental illness, which literally means everyone who had been admitted during that year. And then on the flip side, about 50% of people who were admitted in the mental ward of my hospital here in Eldoret had a substance use disorder. So we see that these two things are happening a lot, quite a bit. It was interesting to see Dr. Blanco talk about how self-medication is not supported by research too much. I think that is what has previously been believed. And it was also interesting to learn that that actually substance use damages the brain in a way that predisposes to mental health conditions. So that, as well as the fact that there's some shared etiology, seem to be the two hypotheses that would explain this co-occurrence of the two disorders. And these rates of co-occurrence are particularly high in treatment settings. So if you look at studies that have been done in hospital settings, like the one we did, the rates are quite high as compared to studies that are done out in the community or in the general population, which really means that the people that we see actually coming in for treatment are quite unwell and often have these two disorders happening together. So this is what I see throughout my practice. One of the greatest challenges I face is teasing these two things apart. Okay, it's usually difficult to tell whether someone has a primary mental illness and then with a co-occurring substance use disorder, or they have a mental disorder secondary to a substance use illness. If you look at diagnostic criteria for mental disorders, we do have this category that's called like substance-induced. So you can have a substance-induced depressive episode, substance-induced psychosis, and sometimes it's very difficult to tell whether a disorder is substance-induced or whether it's a primary mental disorder and then with a co-occurring substance use disorder. And a lot of times family really wants to know, does this person have a primary mental illness or whatever they're experiencing is from substance use. Okay. Very huge challenge. And one that I find particularly difficult to tease apart is cannabis use disorder versus schizophrenia. Would be interesting to hear what Blanco has to say about this. I find this extremely difficult to separate out. And it's mostly because cannabis use in itself increases the risk of developing both short-term and long-term psychosis. But it's also because cannabis also exacerbates an existing primary psychotic disorder. So by the time a patient is presenting for care, it becomes very difficult to know what's happening. Is it a primary mental illness? Is it the cannabis inducing the psychosis? And I think one of the toughest things, again, is that cannabis-induced psychosis can last for quite a period of time. It can go up to sometimes a month. Unlike with other substances like alcohol, where you can have a very brief psychotic episode if it's alcohol-induced, lasting maybe hours or a day, but with cannabis, it lasts for quite a long period of time and can be very difficult to differentiate. So for me, what usually helps me to try tease things apart, if at all it's possible, is the temporal association. I had Blanco talk about that as well, between the occurrence of the mental illness symptoms and the substance use, for example. So if there's been a history of heavy cannabis use today, multiple joints, continuously, and then a psychotic episode ensues, then that's likely to be cannabis induced, as opposed to someone who last smoked cannabis, say 2 months ago, and now is having a psychotic episode. That is less likely to be related to the cannabis and could be because of a primary psychotic disorder. Also, the pattern of use helps me to know what exactly is going on. For example, with cannabis, if there's heavy use and then there's a psychotic episode versus very light use and a psychotic episode, then I can tell whether the episode is induced by the cannabis or the patient is having a primary psychotic disorder. Okay. And also the duration of symptoms. If someone is having a psychotic symptoms 3-4 months after the use of cannabis or alcohol, for example, then that is less likely to be related to the substance use. So these are some of the things that I try and find out: the trajectory of the mental illness, the trajectory of substance use, the pattern of substance use, and so on and so forth, to be able to differentiate those two things. Nonetheless, sometimes it's really, really hard to tell things apart, especially if the pattern of use is not very clear, the onset of symptoms is not clearly described by families. Sometimes, looking back and trying to get a history of what has happened before is not so easy for the patient. So it can be difficult sometimes. And what I do as a clinician is explain that exactly to the patients and family, and tell them that, I'm not too sure what's happening right now. There's these two things that are going on. It really helps me and frees me to be honest in the face of a patient. I tell them there's these two potential things that are going on. It could be that this episode is induced by the substance, or it could be that you have a comorbid substance use and you have a primary mental illness, and only time will tell. And a lot of times when we admit for inpatient treatment and then they are off the substance and also not on antipsychotics and they are well, then that sort of helps you to make a diagnosis as well. But overall, it can be tough to tease things apart. Nonetheless, just as Farid said and as Dr. Blanco said, what matters most is how are we taking care of this person right in front of us, okay? How are we making sure that they are managed in a holistic, they're taken care of in a holistic manner? So we should make sure that when we are, managing a patient with co-occurring disorders, we are paying attention to both of them. You can't have mental health services that say that they don't pay attention to addiction. This is purely mental illness. We are not touching addiction. And you can't say that you're having an addiction service that is not able to offer support for mental health conditions. So making sure that in the services that we are offering, even in the policies that we are making, in the programs that we have for both addiction and mental illness, making sure that they are able to support the other disorder. You cannot have one 100% focusing on one disorder and not the others, And similarly, mental health care providers should have competencies for handling both. So like with the rehabs, we should make sure we have mental health providers that they're able to manage both the addiction and then they're able to manage both the mental health conditions as well. So making sure that the services are offered in an integrated manner. Couple of references. Thank you so much. And I hand it back to you, Candy.
Thank you so much. That was actually quite informative, especially from a clinical point of view, and seeing the kinds of clients that you're getting and the kinds of patients that you're getting. It just brings up multiple questions. And so we've gotten quite a few questions. Let me just share my screen briefly so that we can actually go systematically and see whether we can respond to them. But first off, even before we go into all the questions, you started off really well by this question, Dr. Jaguga, about cannabis use disorders versus schizophrenia, and because they can particularly be problematic, how can we separate them out? And I think you posed this question for Dr. Blanco. So, Dr. Blanco, what are your thoughts?
So, I mean, I completely agree with Dr. Jaguga. No, clinically, it can be difficult to separate. At the same time, I mean, the way I think about the treatment is, well, first of all, I'm not going to recommend to anybody that they use drugs. So if somebody has psychotic symptoms, one of the first things would be to recommend to them that they don't use drugs. That's going to, regardless of the etiology, I think that regarding of the cause, that's going to decrease the psychotic symptoms. And then if they're having psychotic symptoms, I think it's useful to treat with antipsychotics, even though that may be sort of short term. So I think the question in the short term is, let's stop the drug use and treat symptomatically with antipsychotics. I think a more difficult question is long term what to do, no? But I think that can be done in collaboration with the family and the patient, and depending on the symptom evolution, I think you can potentially decrease the dose of antipsychotics. So that would be one way to handle it, no? But I think one of the things that the three of us, Farid, Dr. Jaguga, and I are saying is, I mean, I guess two things. One is we have to be very careful to eliminate stigma, no? I think stigma is something that still sort of gets in the way of treatment and the way of patients and families. I think we often blame the patient for using drugs and for the symptoms, but I think we in a parallel, we don't blame people who use, let's say, who are obese for eating too much. We try to help them have a better diet as opposed to denigrating them. So I think in terms of drugs, we need to help them. And then the second thing, of course, is that even though we're talking about sort of these general principles, it's very important to have individualized patient, no? Because each person is different and the symptoms and the needs of each person is different. We're sort of setting up general rules because that's how science works. But at the end, we have to apply these general principles to the individual person. That's the way I mean, that's only my opinion. No? I don't know if Dr. Jaguga and Farid agree and Dr. Merali, but that's the way I think about it.
I mean, I agree 100% with Dr. Blanco on all of that. Again, it is a stigma thing, right? I mean, it's still, and this is not just here, I think globally, you know, I've been fortunate enough to travel quite far and wide and been, you know, interacted with a lot of addicts in different parts of the world. Here, I think it's the stigma is quite heavy. In other countries, not so much, but there is always going to be, or there has been historically a stigma towards addicts, and I think that is something that, you know, can only be addressed, as I said, with forums like this and with, you know, children being able to talk to their parents and peers and say, I have, you know, this is my challenge, I have an issue. And be open about it. You know, I've said this on a number of platforms, including on platforms with the BMI Institute, and that is normalize conversations about addiction and normalize conversations about mental health.
Thank you. And Kendi, I think that in terms of addressing this issue, I think that we also need to understand. Learn from other illnesses. For example, if you look at HIV/AIDS, there was a highly stigmatized condition. People were blamed for bringing it on upon themselves and ostracized and marginalized. But all of a sudden, when the conversations begin to be normalized by high-profile individuals standing up and saying, "Hey, you know what? I contracted HIV and need treatment and need help." I think when high-profile individuals started coming out and talking about it, slowly the mind shift happened. And as a consequence, more and more research investments happened. And right now, then HIV has become a chronic health condition rather than a death sentence that it once was. So I think that in terms of mental ill health and substance use in particular, I think we need to also shift our mindset and stop blaming the individuals who are really victims of a lot of stress and trauma, and start looking more towards how can we be supportive and help people deal with those issues.
Oh, sorry. And, and I think an important point I want to raise, and I'm happy to hear thoughts from people out here, the fact that in Kenya, substance use addiction is managed out of the healthcare system. So there's a bit of it managed within the healthcare system, but then there's a lot of it that's managed outside of the healthcare system, and it's not managed as a health condition. So does that help to perpetuate stigma? What do we see as a solution in terms of making sure that substance use, and now that we are seeing it's occurring with mental health conditions and it's occurring with multiple physical, conditions as well? Is it something then that should be handled as a health condition and then now handled under, for example, the Ministry of Health and within the healthcare system? I think that would, in my opinion, help to destigmatize things, but happy to hear thoughts from others as well.
Well, one of the thoughts that I was having is that should we really be compartmentalizing addictions a separate issue from mental health issues, or do we just consider addictions as a part of mental health problem and spectrum? And I think that there is some movement, at least in Canada, in terms of, we used to have a Mental Health Commission of Canada and also CCSA, which is the Canadian Council on Substance Use. And the dialogue often is that should there be two separate entities dealing with these issues, or should there be one overarching organization that encompasses both of them as a part of one leading to the other and vice versa, as Dr. Bianco was suggesting earlier on. That's just a thought. I think when we compartmentalize addictions as a separate issue, sometimes we tend to stigmatize it more, where now, as mental illnesses is starting to get less stigmatized, although it's still quite strong, but less so than it was a few years ago. I'm hoping that by incorporating addictions within that framework, that it too would benefit from reduced stigma over the period of time.
We've gotten quite a few questions. Let me share this one. And from Bansi Ngatia, she asks, how can it be explained that some people have a more severe reaction to substances than others? Are there those who have higher tolerance levels than others and thus end up misusing substances even more? Is it just a high biological or psychological threshold? Dr. Blanco, maybe we can start with you, then Farid, and then Dr. Jaguga.
Yeah, I mean, clearly, both at the genetic level and developmental level, there's a lot of variability in the predisposition, both to use substances, but also to develop a substance use disorder once the person has used the substance. And I mean, that's not very different from what happens in other avenues of life. So to just I always like to give examples outside mental health. So some people drink a lot of water, some people drink very little water. So there's a lot of variability. Some people are able to run very fast. I personally run very slowly. So there's a lot of variability. And so the same way that we have these variations for other parts of our life, there's variability in how much substance, the tolerance to substance use, but also in the predisposition to develop addiction.
I fully agree with Dr. Bianco on that one. And I think the other kinds of things that also factor in is that not only could you have a genetic predisposition that you may have inherited, but there is a lot of new evidence suggesting that epigenetic factors that are influenced by your experience could then predispose you more or less to substance use disorders as well. So a very strong case in point is that when you have childhood trauma, when you have adversities in childhood, very often these individuals are much more susceptible to developing not only mental ill health, but also developing substance use disorders. So, so then there is, in addition to the genetic inheritance, you have environment that has either opened the expression or hidden the expression of certain parts of your gene to make you more susceptible to to substances. And so I think that that is an important factor to keep in mind as well.
So, Farid, maybe you could respond to this, because I think you'll be speaking from experience, and maybe you can share what worked for you. But the question was from Rosina. Family always asks, what can they do when multiple structured rehabilitations fail?
You know, I have to point out that my experience in 2018 was based on my desire and inability to get clean. So that's one point that has a lot of prevalence based on the fact that if someone is not really willing and they're an adult, it's very difficult for families to get the message across. It's really difficult to understand as well what an addict goes through. I mean, my view of the world is there are two kinds of people. There are, addicts and non-addicts, and I fall into the category of addicts. And it's very hard for non-addicts to understand what the disease feels like or looks like. So what ends up happening that I've seen is frustration and anger and a lot of micromanaging that person's life because of the fear that if you don't, they will die at some point through their addiction. So I would say from families who are dealing with addicts, the only way is to have as much knowledge as possible when you approach the subject. Don't go in there blind. It's like anything, if you were a lawyer going into a court case, you would do a bit of homework first. I think this is something similar to that. I think you really have to try and understand what an addict goes through, and without being an addict, it's very difficult. So understand that it's not, there are times when I'm telling my story and people are like, why are we celebrating you and you're a drug addict and an alcoholic? And I understand that. I totally get it. My dad, if he was alive, would have asked the same question. Why are people patting you on the back for telling you a story? So I do understand that. But it is a disease. And there was a comment that was just made about we also not really, sometimes it can be inherited, right? I mean, that's a belief system. That's a scientific belief system. My father was an alcoholic. His father was an alcoholic. I'm breaking that cycle. So, yes, I agree. I had my part to play in my use of drugs and alcohol and the behavior that came with it. I will own up to that 100% of the time. But I had such support from my family and such support from my friends. And without that, I think it could have turned out quite differently.
Thanks for that, Farid. We'll try and answer one more question from Muhammad Nawaz. He asks, can someone get rid of their addiction problems after being mentally stable or healthy, or I'm assuming over a period of time?
First of all, is to say that family therapy ought to be a very core component of treatment for addiction. So in addition to taking care of the person who's suffering from the illness, it's important to have, family therapy done as well, and family education. This is how I see addiction from my experience. It's a chronic illness. It's a chronic illness. The brain has changed in certain ways. The environment has changed in certain ways. The social connections, a couple of things have changed in certain ways that, take time to reverse. So I look at it as a chronic illness, just like how you would look at diabetes, like how you'd look at hypertension, like how you would look at asthma. And when I get a patient who's going through addiction, that's part of the explanation to the family and to the patient that treatment is largely long-term. Of course, some people do well. The DSM tells us 12 months after not using substances, you're in remission, but we do understand that vulnerability remains, that vulnerability to having a mental illness, that vulnerability to addiction, still largely remains. So relapse rates, generally, after 1 year of remission, they say about 40 to 60%. So that could happen as well. But there's still hope. It's okay to go out. It's okay to seek treatment. There are people who do well on it. But overall, it's a long-term chronic outlook with addiction.
Thank you for that. I think what we're going to do is we'll just have a final word from Zul, Blanco, and you, Dr. Jaguga, and then we will close the session. So please go ahead. As you do that, I'll be showing what's next on the slides. So feel free to share your final thoughts.
Yeah, for me, the most important thing is for people to know that there are very effective treatments for both mental disorders and addiction. And the shame is not to have the disorder, but really not to seek treatment. And if you seek treatment, the probability of improvement is very, very good. No, so I would encourage everybody to seek treatment if they have a disorder, or to encourage their loved ones to get treatment if they can.
Yeah, for me, I would say out there to the policymakers, it's important that treatment for addiction takes into account the treatment for mental illnesses. Treating addiction outside of the healthcare system and makes it that we are denying people access to the highest, standard of health. So my call out there would be to make sure that addiction treatment services are incorporating mental health care as well.
Absolutely. And I fully concur with those viewpoints. And I think very often you hear clients telling you that when they go for help, if they have addictions, that somebody will tell them, fix your addictions before we treat your mental ill health, or vice versa. They'll say, get your depression fixed before we fix your substance abuse. And the poor clients are in the middle. They fall through the cracks everywhere. And I think that really there's such a huge need for the system of care to be much more open, much more responsive, and much more responsible for actually dealing with this problem right at the community level. So I think that at the primary care level, where you first go to your general physician, your general practitioner, he should be able, or he or she should be able to pick up the issues and guide you to the proper pathways to care. Those are few and far in between, I'm sorry to say. And I think we as a society are failing. We need to really start dealing with these issues much more robustly and much more empathetically, because anybody can fall to addictions. I've seen old statistics, for example, even if you look at the case of cigarette smoking, like a person who ever smoked his second cigarette, chances are 20 years down the line that he would still or she would still be smoking. I mean, some substances become very addicting to some individuals and they get caught in the trap, and we need to help the best we can. So it doesn't matter what the substance is, but we need to kind of treat it as a health condition. And as Florence was saying, find them the right treatment and have them treated into our communities, rather than people like Farid having to go to South Africa to seek for help. I mean, that's not fair and not accessible to most people.
Thank you, Zul. Maybe we can hear the final word from Farid as I share the feedback form. Farid, please share your final thoughts.
Yeah, my final thoughts are just to reiterate exactly what Zul was just talking about, and that is that, there are far too many stories. There is far too little help locally, and I would, can only assume within the region. And I do think that people do fall through the cracks. My father went his entire life as an alcoholic and passed away. For me, it would be 7 years from now. I'll be the age he died. And it was never raised. It was never spoken about. It was never discussed. That is changing, which is great, because the conversation is happening with things like this. But there's still so much more that needs to be done.
Yeah. So just once again, thank you, Kendi, for organizing and the team to put this webinar together so beautifully. Thank you for the panelists for having taken the time to participate fully in this dialogue. And last but not least, all the individuals who have joined in from all across the world. Thank you for joining, and thank you for having an open eye to deal with issues that are so pertinent to our well-being, is the mental health. So with that, I'll say take good care, and hope to see you again at our next webinar.